Hi, my name is Aamir Jeewa, and I'd like to thank the organizing committee for the opportunity to speak today at the Ted Rogers Heart Failure Symposium. And I'm going to focus my talk on heart failure in children with congenital heart disease. These are my disclosures. And I'll begin by an overview of a definition of heart failure, in addition to heart failure in congenital heart disease patients with regard to their pathophysiology and outcomes, and then management of these children, as well as the long-term challenges that these patients face. So one definition of heart failure, and there are many, is a clinical syndrome in which heart disease reduces cardiac output, increases venous pressures, and is accompanied by molecular abnormalities that cause progressive deterioration of the failing heart and premature myocardial cell death. The etiology of heart failure in children can be quite varied, and you can have congenital heart disease related heart failure, so abnormal cardiac chamber morphology or valve function or circulatory connections that are abnormal. In addition, you can also have acquired causes of heart failure, such as myocarditis or toxic exposure, such as chemotherapy. Now, heart failure symptoms due to pulmonary overcirculation, it's a bit of a misnomer to call it heart failure. This is primarily seen in infants and young children, and it's related to increased pulmonary blood flow, so shunt lesions such as a large VSD or patent ductus arteriosus. And the ultimate therapy here is surgical correction for the most part. A general rule is that failure to thrive in an infant is a cardiac problem until proven otherwise. And you can see in these cartoons, you have a ventricular septal defect with a large left to right shunt, as well as a patent ductus arteriosus, which again shows the left to right shunt. And again, these are inefficient circulations that lead to pulmonary overcirculation. But the main part here is that the pump works fine. Now, there are low cardiac output states in children as well, too, and there are congenital reasons for this, and as well as primary or acquired reasons. And so congenital reasons can be obstruction to aortic flow, which can present with decreased pulses, pallor, and a frank circulatory collapse. And this can be seen in things like in lesions such as hypoplastic left heart syndrome or aortic stenosis. And these are ductal dependent lesions, and so when the ductus closes around day 2 to 14 of life, this is when they can present with their heart failure symptom. There are primary or acquired diseases of the myocardium, such as dilated cardiomyopathy or myocarditis, and they can have similar features as well as a displaced cardiac apex, gallop rhythm, soft heart sounds, and a murmur of valve regurgitation. Now, these graphs show a distribution of cardiac output in the resting normal state and heart failure. And you can see here that though there is reduction of blood flow to the skin and to the renal organs, there's overall preservation of blood flow to the brain, heart, and splanchnic circulations. And thus, you can see that the changes in heart failure really lead to a preservation of end organ function as much as possible. And so I think it's always helpful to go through a case, especially when we're talking about congenital heart disease and heart failure. And so we recently had a case of a 16-year-old male with weight loss and exertional fatigue. He had a history of complex congenital heart disease, a lesion called congenitally corrected transposition of the great arteries. He had worsening heart failure over the past 6 months, and prior surgery included a pacemaker as an infant. But he presented with tachypnea, tachycardia, and dyspnea. He was very thin. He had decreased heart sounds and a 3 out of 6 systolic murmur with a gallop rhythm. And he had hepatomegaly and an elevated JVP. And just to kind of further explain, CCTJ, as you can see here, is where the heart is connected with a normal right atrium to a morphologic left ventricle, which then pumps to a pulmonary artery circulation. And then a left atrium connected to a morphologic right ventricle, which pumps to the aorta. And a morphologic right ventricle was never meant to pump into a systemic circulation. And so these patients can have heart failure due to a failed right ventricular or systemic ventricular function in the long term. And these echocardiogram clips, the one without color shows the dilated left atrium and the morphologic right ventricle with decreased ventricular function. And the one with a colored Doppler there shows that blue flame of severe valve regurgitation, which also was an important factor in his heart failure. And so when we talk about congenital heart disease and heart failure, there's often three pathways that this leads to. And so congenital heart disease with either incomplete correction of their lesion or a failed correction of their lesion or an undiagnosed shunt will then have chronic pressure or volume overload and mechanical injury of heart tissue and fibrosis, which could lead to heart failure. You can also have congenital heart disease with their congenital malformations and overlap with certain cardiomyopathies. And we've seen this with Noonan syndrome and hypertrophic cardiomyopathy with congenital heart disease, and as well as conditions like LVNC, which is a form of cardiomyopathy that can overlap with congenital heart disease. There are also genetic causes of congenital heart disease that converge with heart failure pathways, and this can lead to a predisposition to heart failure in the setting of chronically abnormal hemodynamic stress. Now, data with regards to outcomes is also very important, and the Pediatric Cardiac Critical Care Consortium looked at over 1,500 patients admitted to a cardiac ICU, and of those, about 850 of them were congenital heart disease patients for acute decompensated heart failure, and a little over half of them were congenital heart disease patients. And as you can see in this ICU group, that the patients with congenital heart disease were more often underwent mechanical ventilation or reintubation within 48 hours or other forms of positive pressure ventilation, and also required invasive hemodynamic monitoring. As well, congenital heart disease patients had extracardiac abnormalities, chromosomal abnormalities, or syndromes, not surprisingly. But what is interesting is that congenital heart disease patients were often less likely to be listed for heart transplant or to be given advanced heart failure therapies such as ECMO or ventricular assist devices. And congenital heart disease patients were at higher risk for an ICU mortality and hospital mortality overall. And in addition, had also a higher degree of a 30-day rehospitalization after discharge. And when we look at pediatric heart failure admissions as a whole, you can see that the children who are less than 1 year have the highest likelihood for death. And in addition, pediatric heart failure patients have much longer lengths of stay in hospital compared to their adult counterparts. And so getting back to the case, our 16-year-old male with CCTGA and heart failure was able to be rescued with inotropes, but was unable to wean from milrinone and diuretics, and eventually required listing for heart transplantation. However, we are able to manage patients with home inotropes, and so he was discharged from hospital with a home milrinone program in a PICC line, and he remained an outpatient for a few months, but then was readmitted for worsening heart failure, and as you can see, the BNP was also elevated. Now, this diagram just shows the assessment of pediatric patients with acute decompensated heart failure and how we classify them. And as you can see that if you have no congestion or no concerns about perfusion, then you're in that group A box. But if you have congestion and low perfusion, then you'll have signs and symptoms such as a narrow pulse pressure, cool extremities, orthopnea, high JVP, and ascites. And children aren't small adults, and they can present with heart failure in different ways, and it also depends on the varying ages of the child themselves. A baby will have different heart failure symptoms and signs compared to an adult or an older age child. And so it's important to look at all the different organs, specifically with regards to their presentation. But I will say that feeding intolerance, anorexia, nausea, and vomiting are one of the main ways that small children tend to present with heart failure. And things like pedal edema and elevated JVPs are less common. Our heart failure investigations include echocardiogram, chest X-ray, growth parameters, as we mentioned about failure to thrive earlier, echocardiogram, biomarkers. But what is also important for congenital heart disease patients with heart failure is cardiac catheterization and MRI. This helps us get the invasive hemodynamics, but also can be therapeutic in that if there are lesions that can be addressed by catheterization and intervention, then that can help modify some of the heart failure symptoms. In addition, MRI can provide that advanced imaging to really delineate some of the changes in the myocardium or any kind of residual physiologies that need correction. We also do the workup that we would do for cardiomyopathy patients, such as metabolic workups, or looking for infectious causes for myocarditis. And the management of heart failure, we do, and these are common themes that are seen in adult heart failure. We strive for afterload reduction and beta blockade, and for symptomatic heart failure, we use diuretics and digoxin and attempt fluid restriction. And this roadmap for heart failure management is quite helpful because in the initial management, we will use inotropes and IV diuretics and positive pressure ventilation to try to get out of try to get into the rescue phase. And then we will measure those indicators of end organ perfusion and symptoms. And if there's a stabilization, then we aim to try to convert from IV medicines to oral therapies and to get back to rehabilitation and outpatient management. However, if there are deterioration in those markers, then the patient may need mechanical circulatory support or mechanical ventilation as well. These are commonly used medications, and so ACE inhibitors and angiotensin receptor blockers are also used in pediatric heart failure to help modify the renin-angiotensin-aldosterone system. We also commonly use diuretics here as well too to try to help with symptomatic heart failure. But it is important that independent predictors of mortality in heart failure are often associated with a high wedge pressure, low serum sodium, an increased end diastolic dimension or the size of the heart on echocardiogram, and poor cardiopulmonary exercise testing. And that some of the invasive measures such as right atrial or pulmonary artery pressure or cardiac index don't necessarily predict the outcome. And so patients admitted with heart failure and fluid overload should be treated with intravenous loop diuretics. Therapy should begin in the emergency department or outpatient clinic without delay, as early intervention may be associated with better outcomes for patients hospitalized with decompensated heart failure. And this is a recommendation from the AHA and the ACC. And here the therapeutic goal really is to reduce filling pressures and congestion while preserving stroke volume and end organ function. And you can see that if there is an early, timely approach to this, then the pressure volume curves can remain as close to normal as possible. However, if it is very delayed or chronic in nature, then there may be little in the way of trying to remodel some of these factors. And this is just a summary slide with regards to the medications that we use with regards to ACE inhibitors or angiotensin receptor blockers, inotropes that improve myocardial contractility, but often at the cost of increasing myocardial work. And we often use epinephrine or milrinone. And then when it comes to beta blockers, the adult studies have been very powerful with regards to the mortality benefit of beta blockers. The pediatric data is not as consistent, but we do still use them in symptomatic heart failure, and as well as digoxin. However, the use is also controversial in pediatrics. And it is important not to forget that these patients who have poor ventricular function are predisposed to developing intracardiac clots. And this echocardiogram clip just shows an intracardiac thrombus there. And so anticoagulation for patients with a reduced ejection fraction or intracardiac clots is also a part of the management algorithm. And so for our patient who was on home milrinone for a period of time, due to recurrent heart failure hospitalizations and failed outpatient management, he underwent a ventricular assist device implantation as a bridge to transplant. Additional challenges of implanting a VAD in congenital heart disease are also important considerations, as the anatomy is not straightforward, and implantation of these devices can take on additional challenges of correcting residual lesions or valve repairs. He was rehabilitated post-operatively and was discharged after 1 month and had a successful heart transplant a few months after his VAD implant. And these are the types of devices we'll use in pediatric patients as well too. And these artificial heart pumps will be implanted in the ventricular apex, and they can help bypass the native heart function. And for this particular patient, you can see the pre-VAD chest X-ray shows a marked cardiomegaly with increased pulmonary congestion. And then after the device implant, the heart size was reduced and the chest fields were much clearer. With regards to significant mortality, morbidity, and resource utilization in children with heart failure and congenital heart disease, this U.S. data on 460,000 congenital heart disease hospitalizations showed that heart failure admissions are increasing over time between 2004 and 2015, and that the mortality was higher in single ventricle patients, persons of color, and chronic complex comorbidities. And the median hospital cost per patient was $250,000, which was 6 times greater than in those without heart failure. And these diagrams just show the increasing number of heart failure hospitalizations, as well as the increased mortality in the younger patients with congenital heart disease. And so it's important to remember that this is a progressive disease with recurrent hospitalizations conferring a poor prognosis. And that really needs to also be kept in the spectrum of quality of life and palliation. And that though we have ultimate goals of trying to cure or restore therapies, over time with recurrent hospitalizations and worsening heart failure, palliation is also an important part of that treatment pathway. More than 90% of children with congenital heart disease live on to adulthood. And there are over 3 million children and adults living with congenital heart disease. And so it's important that these children will go on to become adults and will have lifelong challenges with regards to valve problems, pulmonary hypertension, arrhythmias, and heart failure. And so it's important to have adult colleagues, such as the group at Toronto General Hospital, who can help to provide a multidisciplinary approach for their emotional and physical needs, and can help them really take on the lifelong challenges of congenital heart disease and the potential for developing heart failure. And so in summary, heart failure, secondary congenital heart disease is a complex and evolving syndrome that is influenced by both primary and acquired factors. Among the highest risk group for mortality with need for significant resource utilization, and requires lifelong management, follow-up, and dialogue. Thank you for your time today.